Primary angle closure disease acute recap. So our first talk is on gonioscopy, tips and tricks by Dr. Maya. Maya is a consultant in Little Flower Hospital, Angamali.
Good morning all. I am presenting on tips and tricks on gonioscopy. Gonioscopy forms part of a complete ophthalmic examination which every ophthalmologist must be able to perform. Why do we need gonioscopy? It is due to the optical principle of critical angle. The light rays coming from the anterior chamber angle strikes the cornea at an angle which exceeds this critical angle. Thus, it gets reflected back into the anterior chamber, preventing direct visualization of the angle. So we use a contact lens which bridges between the anterior film and the cornea. Anterior curvature of the contact lens in direct gonioscopy is such that the angle of incidence is less than this critical angle and the light rays are reflected at the new contact lens air interface and we get an erect image of the angle structures, and in indirect gonioscopy we get a mirror image of the angle structures. Who needs gonioscopy? Ideally all patients. It must be performed at least in all glaucoma suspects where suspicion is based on family history of glaucoma, intraocular pressure, Van Herrick's test, optic disc appearance. Also in patients with history of ocular trauma, uveitis, patients suspecting secondary glaucoma. It is also used to assess the angle after laser peripheral iridotomy. And also if there is any unexplained change either in the intraocular pressure spike or field progression, which all lenses should be used. These are the indirect gonioprisms, Goldman single mirror and 3 mirror lenses, which uses a coupling agent to fill the space between the cornea and the lens because of their 7.38 mm posterior radius of curvature. These are the other indirect gonioprisms, C's 4 mirror, Sussman and Posner, which doesn't need a coupling fluid. The other trabeculoplasty lenses are Rich and Latina. Direct gonio lenses are Cope, Barkan, Schwann-Jacob and hands-free gonio lenses. Coming to the technique, do an external eye examination first, then do tonometry before gonioscopy, explain the procedure to the patient, use a topical anesthesia, make the patient seated comfortably with chin resting and forehead touching the headband and both eyes open. The examiner's elbow should be supported to avoid undue pressure over the globe. Place the lens directly over the cornea. In nervous patients, ask the patient to look up, insert the lens quickly without much loss of coupling fluid and then ask the patient to look straight. This is how the patient should be seated, how the lens is held in position. Indirect gonioscopy, hold the lens with thumb and index finger and brace the other fingers against the patient's face or slit lamp's headband. This allows to rotate the lens continuously without using the second hand and letting go of the slit lamp controls. Keep bubbles out of the methyl cellulose as it will obscure your view. It should be done in a fairly dark room. Pupillary constriction makes a narrow angle appear more open. Use higher magnification of 10 to 25x. Use a fairly short and narrow beam of 2 to 3 mm. If the lens sticks to the eye after examination, ask the patient to tightly close the eye and try detaching the inferior margin of the lens first. Then what to look for? First, identify the angle structures, assess the angle occludability and then look for other findings in the angle. Identifying the structures from anterior to posterior is mostly preferred. First, identify the Schwalbe's line, which appear as a fine ridge. It is identified by small buildup of pigments. Anterior trabecular meshwork is the second one, which is a white band posterior to the Schwalbe's line. Then comes the posterior pigmented trabecular meshwork, which is a pigmented band posterior to the anterior trabecular meshwork. Then scleral spur appear as a prominent white line posterior to the posterior trabecular meshwork. Ciliary body appears as a grey to dark brown or slate colored band posterior to the scleral spur. Many times, Schwalbe's line may be mistaken for posterior trabecular meshwork due to the pigment dispersion along this line, and this is called Sambolos's line. But in this, the pigmentation will have a salt and pepper appearance, dark and granular, and it will be discontinuous. And pigmented trabecular meshwork, the pigmentation will be brown, fine, and continuous. We can identify the Schwalbe's line with the method of corneal wedge. When a thin slit of light hits the iridocorneal angle at an angle of 10 to 15 degree, two light reflections are seen from the external and the internal corneal surfaces, which pipe down at the corneoscleral junction. This points towards the Schwalbe's line. When the iris has a convex configuration, it is difficult to see the angle structures. Then ask the patient to look in the direction of the mirror or move the mirror towards the angle being viewed. This gives a better view of the angle structures. Now, assess the occludability. An angle is considered to be occludable if the pigmented trabecular meshwork is not visualized in more than 180 degree of the angle without indentation under appropriate testing conditions. Indentation gonioscopy. When iris covers the trabecular meshwork, it's easy to mistake the non-pigmented trabecular meshwork for scleral spur, pigmented Schwalbe's line for trabecular meshwork, oppositional from synechial. In this, indentation gonioscopy is particularly useful. Indentation gonioscope is used to apply pressure axially towards the center of the eye while the patient is looking straight. Oppositional closure opens upon indentation. It also helps to identify the plateau iris configuration, which is due to anteriorly inserted ciliary process. This gives a sine wave and double hump sign on indentation. Then increase the illumination, see for other structures in the angle like abnormal vessel, silicone oil, peripheral anterior synechial, plateau iris configuration and pigmentation, pseudoexfoliation, and in trauma, iridodialysis, angle recession, cyclodialysis cleft. Iris processes are fine, they extend into the scleral spur. Underlying structures can be seen in between, and these will be broken in angle recession. Peripheral anterior synechial will be broad, it extends beyond scleral spur and obscures the view. The normal iris vessels have a radial orientation, and angle vessels are fine, arborizing and crosses scleral spur. Angle recession. In this, the ciliary body band will be wide. They will have a deep anterior chamber and also compare with the other eye. Iridodialysis is the separation of the root of iris from the ciliary body. Cyclodialysis cleft, you can identify the white color of the sclera which is visible. Then direct gonioscopy is performed by a binocular microscope and illuminator. It is done in supine position. Lens is positioned with coupling fluid. We get an erect view. Examiner can scan 360 degree by shifting his chair. It is contraindicated in painful inflamed eye, compromised cornea, suspected open globe injury, or early in course of suspected closed globe injury with hyphema, as the pressure may precipitate rebleed. Then sterilize the lens. So wash with soap and water, soak in 1% sodium hypochlorite for 5 to 10 minutes, rinse and air dry. The secret for a good gonioscopic view is practice, practice and practice. Thank you.
Thank you, Dr. Maya. That was a very good presentation on the basic technique gonioscopy. Now I invite Dr. Meena Nair, a senior consultant in Chaitanya Eye Hospital, to present on imaging techniques in angle assessment. Can they replace gonioscopy?
Good morning. At the onset, I wish to thank Dr. Girija and KSOS for the opportunity. And in the next 7 minutes, I'll be talking on imaging techniques in angle assessment, whether they can replace gonioscopy through a series of case scenarios. The first one is a lady who was referred to the glaucoma clinic for gonioscopy who before posting for cataract surgery. And note the irregular Van Herrick's in the slit lamp picture and the convexity in the inferior 1/3. Gonioscopy showed that the inferior quadrant, the temporal 1/3, had appositional closure, no PAS, and we went ahead with the UBM. And note that the UBM, the lower image, you can see the cyst, iris cyst, which is pushing the iris peripherally to the cornea, and the upper images can show you the multiple small ciliary body cysts as well. So this imaging modality picks up extra features and goes behind the iris to pick up the mechanism for secondary angle closure. This is another patient of mine who's being serially followed up with its irises to know whether the size and extent is increasing, and you can see it's almost same. So this imaging modality has a very good role at giving us additive information on things behind the iris. The gonioscopy in this case also showed 180 degrees of appositional closure in the superior and temporal quadrant. Now the third patient is a young chap who had undergone toric ICL recently and was referred referred to the glaucoma clinic. 1 week, this is the right eye, 1 week post-operative. Actually, he had some mild symptoms which was suggestive of an IOP rise. But then when referred to the glaucoma clinic, cornea was clear, it was 6/6 vision, and the intraocular pressure was normal. And this swept source anterior segment OCT actually delineates well the anatomical landmarks of the anterior chamber angle, the scleral spur, and the trabecular meshwork. And you can see on the left-hand side that the angle is definitely open. Apart from that, the lens vault is an important concept which can be observed on the anterior segment OCT. And this patient was serially followed up also. This is the other eye which was 1 day follow-up, and you can see that there's a 200 micron difference in the vault, but still all parameters were normal and his IOP was normal. At 2 weeks in the right eye, he had again some blurring of vision. And then what is to be thought of is, though the anterior segment OCT parameters were normal, something else had to be done, and that was the gonioscopy, which revealed the pigmented trabecular meshwork. In fact, the inferior quadrant, there was blanketing of the scleral spur, and all the other trabecular meshworks in the other quadrants were also having dense pigmentation. So looking back, a review of the slit lamp showed that there were a few floating pigments in the anterior chamber, as well as a few pigments on the ICL surface. So this just shows us that how important gonioscopy is. Now, fourth patient actually walked into our clinic, operated elsewhere a year back, and now coming with an IOP of 30 with a relatively clear cornea. And you can see the pseudo-exfoliation peripupillary in the picture on the right. And on the left, you can see the gonioscopy showing that no angle structures could be seen 360 degrees. So the B scan showed there is no secondary pathologies, and what could be thought of, it could be either a pseudo-exfoliation glaucoma or a secondary, probably a capsular distension syndrome. And we went ahead with a UBM, and that shows the Somering's ring, which is pushing back the iris towards the cornea, and probably there is a cleft as well. So after the image below shows that after an iridotomy, the iris contour was flat and the angle had opened up, and the intraocular pressure with one medication was normal. The vision was also 6/9, and the gonioscopy showed there was 270 degrees of PAS, indicating the chronicity of the whole picture, because of which an topical anti-glaucoma medication had to be given. The next case is a patient again operated elsewhere 6 months back, intraocular surgery done, comes to us with a decentered inferior IOL and with hypotony. Mark you, when I checked the intraocular pressure, the IOP with GAT was 0. And when we went ahead with an ASOCT, which showed a fibrinous network in the anterior checker. You can see the OCT onlay view showing the dense fibrinous network. So a course of systemic steroids along with topical steroids was given, and in 2 weeks' time, the entire anterior chamber had cleared up, but the intraocular pressure was still 0. And then what to do next? So a UBM was done, and you could see the supraciliary effusion there, which could explain some amount of the low IOP. But a crucial look into the anterior segment OCT picture showed that at the site of the incision, where there is a ragged scleral incision, you have the iris incarceration. And gonioscopy in the scenario of low IOP of 0 was difficult. And a repicture of the ASOCT through the same cut section showed that the wound architecture was weak. So the patient was posted for a wound exploration, and the next day after the surgery, the IOP had gone up to 20. So you see what complementary each investigative tool complements one another. Now, this picture is a lady who was referred to us by a neurologist with chronic headache. She was on topiramate for 6 weeks and was referred to us. And we found there is a grade 3 nuclear sclerosis with shallow AC. And you can see that in the right eye, there is synechial closure, nasal nearly 180 degrees. The left was open and the pressure was normal. So we did an ASOCT to rule out a supraciliary effusion, which was not there. So the drug-induced secondary closure was ruled out, and the lens vault as well as lens thickness was noted to be high in both eyes. So the patient underwent an PI followed by cataract surgery was advised to the patient. The next is a patient who had undergone ICL about 10 years back and then had fungal keratitis, was treated elsewhere, and now the sequelae of the corneal opacity. So in this opaque cornea, the patient came to attend our cornea clinic and again to a glaucoma clinic because the patient was on topical anti-glaucoma medications, 2 drugs. And we noted that in this scenario, you can see the ASOCT showing you the superior patent surgical iridectomy, and the pictures actually showing you that it has open angles. So the cornea department has posted the case for a DSEC. And this is the next patient who actually has a unilateral anterior segment dysgenesis. You can note the mid-peripheral anterior synechiae. A gonioscopy is showing you the broad-based peripheral anterior synechiae, which is anterior to the Schwalbe line for almost more than 180 degrees. And the UBM taken cuts through those point PAS, does reveal the extent of the anterior peripheral anterior synechiae and confirms our picture. This is a patient who was a trap done, the right eye, a revision trap done in 2007. And you can see in the overlay pictures that the patient has an end-cysted bleb. And this is the other eye, which is doing very well with no glaucomata. So optic neuropathy, who had undergone trap at the first go, and this has a functioning bleb. You can see the internal ostium and the root well, and it supports your clinical diagnosis with the gonioscopy as well. So coming to the last picture, where you have a gonioscopy showing the double hump sign, which my previous speaker has just shown you, and the same can be actually correlated with the non-contact modality, the ASOCT, where you can see the flat contour along with the closure, and you can see the iris angulation, the steep angulation, and the near appositional closure with the anteriorly directed ciliary processes. So for plateau iris, it helps to confirm your diagnosis and correlate your findings with gonioscopy. So the nutshell is that indentation gonioscopy, dynamic indentation gonioscopy, is a current reference standard for assessing the anterior chamber angle structures as well as their configuration, and all the other imaging devices, though they cannot replace conventional gonioscopy, these techniques are useful in complementing clinical practice, especially when gonioscopy is difficult. Thank you.
Thank you very much, Dr. Meena. Very practically illustrated case-based examples. Thank you very much. Next speaker is Dr. Smita VK. Dr. Smita is Senior Glaucoma Consultant at Little Flower Hospital, Angamali. And Dr. Smita is going to speak to us about classification and clinical features of primary angle closure disease. Over to you.
Good morning all. My topic is classification and clinical features of primary angle closure disease. Primary angle closure disease constitutes about 3 to 5% of Indian population over 40 years. It occurs when an anatomically predisposed eye undergoes physiological changes in the configuration of iris, which leads to apposition of the iris to the trabecular meshwork. This iridotrabecular contact prevents the aqueous outflow and results in increase in IOP. This increase in IOP depends on the extent of circumference of the angle closed and the speed with which it is closed. The relative pupillary block is the main pathomechanism for the angle closure. And here, when the pupil is mid-dilated, the iris is in contact. There is more iris contact with the lens, which leads to increase in pressure in the posterior chamber. This increase in pressure in the posterior chamber prevents the aqueous, leads to the iris bowing peripherally, which leads to the iridotrabecular contact and prevents the aqueous outflow. The risk factors include age. With increased age, there is increase in the lens thickness and there is forward movement of the lens, which results in angle closure. And females are more prone for angle closure disease, and hypermetropes are more likely to have angle closure. And Southeast Asian population is at more risk. And if there is a family history of angle closure, there is high risk for angle closure. And the ocular biometric factors include shallow anterior chamber, thicker lens, anteriorly positioned lens, shorter axial length, small cornea, anterior insertion of the iris, and steeper cornea. If the pupil is mid-dilated, especially in twilight or in theaters, there is increased risk for angle closure. And with increased stress, there is pupillary mydriasis, which leads to angle closure. With the new techniques like UBM and anterior segment OCT, newer factors, anatomical factors have been identified. It includes the decrease in the anterior chamber width, area, and volume. There is increased risk for angle closure. And if there is increased iris thickness, increased iris area, and increased iris curvature, it can lead to angle closure. And increase in the lens vault is another factor which leads to angle closure. And choroidal expansion can lead to forward movement of the iris lens diaphragm, which can cause angle closure. This is the pictorial representation of this. And clinically, the angle closure glaucoma can be classified into a preclinical stage when one eye is in acute attack, the other eye is said to be in the preclinical stage, and it can go into an attack stage where it may be a mild attack or an acute attack. In mild attack, there is incomplete closure of the angle with mild rise in IOP and symptoms, while in acute attack, there is sudden increase in IOP with complete closure of the angles, and this can reverse to go to an intermittent stage when the angles can get opened and IOP getting controlled. If the angle keeps on closing, then it can go to a chronic stage where where there is increased IOP and glaucomatous damage. And in absolute stage, there is a refractory eye pain with glaucomatous optic atrophy. And ISDO is classified primary angle closure disease into primary angle closure suspect, primary angle closure, and primary angle closure glaucoma. This helps in planning the management of angle closure, but this ISDO has not taken into account the optic nerve damage or trabecular dysfunction. So, in primary angle closure suspect on gonioscopy, we can see an occludable angle. Here, the posterior trabecular meshwork is not visible in 180 degrees of the circumference of the eye in primary gaze without indentation, and you have to use a slit beam of 1 millimeter height. And shallow anterior chamber is seen in primary angle closure suspect, and where Van Herrick estimation, in Van Herrick's estimation, we can compare the peripheral anterior chamber depth with the peripheral anterior corneal thickness, and if it is less than 1/4, then they are more prone for angle closure. And in primary angle closure, there is an occludable angle with signs of iridotrabecular contact and with or without raised IOP. The signs of iridotrabecular contact include peripheral anterior synecdoche, iris swelling, blotchy pigment deposition on the trabecular surface, and glaucoma flecken. And you have to see the optic nerve head carefully, as the disc will be small and we can miss the glaucomatous changes. In primary angle closure with hypertension, the eyes will have increased IOP, and this may be due to the peripheral anterior synecdoche, or if the angles are open, it may be due to the deranged trabecular meshwork architecture and function. In acute angle closure glaucoma, the patient has diminished vision, eye pain and headache, sudden onset of headache, nausea, vomiting, rainbow colored halos, etc. And the signs include increased IOP, circumcorneal congestion, corneal edema, shallow AC, vertically mid-dilated, poorly reacting pupil, and a closed angles on gonioscopy with a swollen hyperemic optic disc. And the signs of previous episodes of angle closure include Vox triad, which includes segmental iris atrophy, pigment dispersion, and glaucoma flecken, with a fixed mid-dilated pupil, shallow anterior chamber, and peripheral anterior synecdoche on gonioscopy, with posterior synecdoche to lens and optic nerve head pallor or cupping, and visual field constriction. In primary angle closure glaucoma, there is an occludable angle on gonioscopy with more than 180 degree of peripheral anterior synecdoche and raised IOP, and there is glaucomatous optic neuropathy with visual field changes. Chronic angle closure glaucoma, the portion of the angle closed permanently with peripheral anterior synecdoche and IOP is raised. The angle slowly closes from the periphery towards the Shalby's lines. So usually starts in the superior quadrant and it progresses inferiorly. This is called, otherwise called creeping angle closure. And in plateau iris syndrome, it usually occurs in young people when despite the laser PI, after laser PI also, if the IOP patient gets acute attacks, then you have to suspect this plateau iris syndrome. Here the anteriorly positioned ciliary processes push the peripheral iris anteriorly and it gets punched up and leads to the closure of the angle. And gonioscopy shows double hump or sine wave, and UBM is confirmatory. Thank you.
Is YAG-PA indicated in all cases of primary angle closure suspects?
Good morning, ladies and gentlemen. At the outset, I would thank Dr. Girja and KSOS for this opportunity. Our previous speakers have spoken about angle closure glaucoma, its classification and imaging. The question I would like to address is YAG-PA indicated in all cases of primary angle closure suspect? The mechanism of angle closure, as you know, YAG-PA really only helps in the case of pupil block or relative pupil block, where you have an iris Bombay-like appearance. But there can be other mechanisms like plateau iris configuration, lens-induced or lens factors, and ciliary block and posterior pushing mechanisms. So really, YAG-PA does not help in these. It's mainly in the case of pupillary block. So the question I'm trying to address here, this is what is usually recommended. The indications for YAG-PA in primary angle closure suspect are: one, if there's a history of primary angle closure in the other eye, or if it's a one-eyed patient. A relative patient requiring frequent dilatation. As you know, Kerala is now the diabetic capital of India. So many of our patients are diabetic and they need once yearly at least dilated fundus examination. People unable to come for regular follow-up. Now, as you know, with the changing demographics of Kerala, all of our youngsters are moving away to UK and Canada and US. And so our elderly patients very often go to visit them for extended periods of time, 6 months, a year, or maybe longer. And unfortunately, in places like UK and Canada, the healthcare, our access to healthcare is not great. And very many of them are not able to see a doctor or an ophthalmologist when they are there. And as you know, US also, it is completely controlled by insurance. So this is also something that we need to keep in mind. With increasing longevity, more of our patients are on medications, asthma, Parkinsonism, allergy. Unfortunately, a friend of mine, his mother, unfortunately developed bilateral angle closure due to treatment for acute asthma. So these are considerations that we need to keep in mind, and it's not just the eyes that we are looking at. We need to consider the patient as a whole. I had two patients once who had seen, and I thought occludable angle, and then when I gave them an appointment for YAG-PA, when they came, the angle had opened relatively, and then asking them, they were taking medication for allergy the first time when I was seeing them. So all these are things that you need to keep in mind. Symptoms suggestive of previous primary angle closure, definitely they are patients that you do not want to wait and sit on. Patients should understand the risk, and then with their consent we can do a YAG-PA. YAG-PA is not without its complications, which is why we always need to keep that in mind. So usual complications like bleeding, corneal pitting. Some complications are very disabling, like dysphotopsia. It's the patient who had a YAG-PA. Unfortunately, the PI is just exactly where the lid was cutting the limbus, and he had severe dysphotopsia symptoms. Another patient who had a YAG-PI done elsewhere came 17 days post YAG-PI with a complaint of floaters, and he had a retinal hole with an operculum exactly corresponding to the PI. So unfortunately, the YAG laser had gone through the iris and hit the retina. So this is always something that we need to keep in mind. So the reason for our rethink is these two big studies, the ZAP study from Guangzhou in China and the analyst study from Singapore. The ZAP study had a first results which came out in 2019 and then followed in 2021, and the analyst in 2022. And let's have a brief look at these. So the ZAP study, nearly 900 patients followed up for 6 years, all with PSCS. And what they looked at was the risk of primary angle closure. So there was a 50% reduction in risk of primary angle closure if they had a YAG-PI done. But the numbers needed to treat was 44. And there was a hazard ratio of 0.53. Now the follow-up, they did follow up these patients even further, and they came out with a 14-year result where the numbers needed to treat came down from 44 to 12.35. So in effect, you treat 12 patients to prevent angle closure in one patient. I think that is still justifiable. I feel even if you can prevent one angle closure, I think it is justified. The other big study was the analyst study. You can see here again nearly 500 patients followed up over 5 years. And again, you can see there's a 50% reduction, 11 versus 21 in the treated and the untreated eyes. And the numbers needed to treat was 22. This is a patient I saw with acute angle closure, as you can see, it's really a real struggle to get them, treat them and get them to get the IOP under control. So, and also this article came out in IJO recently, February 2024. You can see the rough ratios of primary angle closure suspect, primary angle closure, and primary angle closure glaucoma, 10:2:1. So this is why people are rethinking whether we should go ahead and do a YAG PI. And also they say that once the patient has had an acute attack, even doing the YAG PI may not really solve all the problem, because many of them have got a iris atrophy, angle closure, which is also synechial closure, which does not really open up with the YAG PI. So what do I do? Of course, a good clinical examination, AC depth, iris configuration, gonioscopy. So make sure this is a patient with a relative pupillary block in whom you are actually justified in doing a YAG PI. With this clinical examination itself, you can differentiate those patients who actually have a relative pupillary block, the peripheral shallow AC with a convex iris. That's the primary angle closure that we need to address. But in the other cases, where the whole anterior chamber is shallow, most likely it is the lens factor that are operating, and also central and peripheral shallow AC, the forward movement of the lens. Irregular AC depth probably means an irisis, lens subluxation, and other factors. So those are patients where YAG PI really is not going to help. And again, clinical examination, where you can image them and document them. And as I said, history of drug use, history of travel, all these need to be taken into consideration when you manage the patient, and discuss with the patients, and if suspicious, do a YAG PI. Thank you.
Thank you, sir, for that excellent talk. Now, I would like to invite Dr. Ronnie George for his presentation. Is the lens the real culprit in PACD? If so, is clear lens extraction a remedy? Sir is the head of glaucoma services, Shankar Nethralaya, Chennai.
Thank you. Thank Dr. Girija and KSOS for the invitation. And I've been asked to speak on how the lens, whether the lens is a real culprit in PACD. So I'll try and answer two questions. One is, how much does a lens contribute to PACD? And also we'll discuss briefly the rationale for clear lens extraction that is currently postulated. So I'll just come to biometry first. So this is data from the Chennai glaucoma study. What we did is we looked at axial length, anterior chamber depth, and lens thickness, and we divided them into 10 equal groups. So 10 deciles of measurements. So this is the axial length data, and what you have is the shortest axial length on the left side and the longest axial length on the right side. And you have the proportion of angle closure disease in each of these deciles. And you can see quite clearly that about 65% of people in the shortest 10% of eyes had some form of angle closure disease. But you also had some angle closure disease even in the longest eyes. If you look at anterior chamber depth, again, very similar numbers. So you're seeing in the shortest 10%, you're seeing almost 90% of the eyes with the shallowest anterior chambers had angle closure, as compared to maybe 10% of the deepest eyes. But when you look at lens thickness, the picture changes a little bit. You have two peaks. One peak is in the eyes with the thinnest lenses, and one peak is in the eyes with the thickest lenses. And you also have some floating around in between. So this is a little unusual, because you would expect thicker lenses to all have angle closure and the thinner lenses to not have. So then we tried to see whether the relative lens position, or the position of the lens relative to the length of the eyeball and the anterior chamber depth, that's calculated using this formula. What happens once you factor that into the equation? And once you factor that into the equation, you again see the same sort of picture, that the eyes with the most anterior relative lens position were most likely to have angle closure, as compared to eyes with the most posterior lens position. So what this tells you is that the lens does play a role, but it is not a consistent role. The role of the lens is dependent on the size of the eyeball and the crowding of the anterior segment. So knocking off the lens in everybody just doesn't make any sense, because this is the way it looks. So then I'll switch to this study, which looked at the quantitative evaluation of anterior segment parameters using ASOCT to look at primary angle closure mechanisms. So what they did here was they took ASOCT images and they divided them into 4 mechanisms of primary angle closure. Pupillary block, which is this one, Plato iris configuration, thick peripheral iris roll, and the fourth is the lens vault. And based on this, they measured many things, but what we are really interested in over here is the lens vault. And this is what they found. They found that 33% of eyes had an exaggerated lens vault. The rest were other mechanisms. Pupillary block was about 30%, Plato iris and thick peripheral iris was the other 30%. And you can see from this is a graph which shows the lens vault in each of these conditions. You can see the eyes with an exaggerated lens vault had an average of more than 1.2 millimeters as compared to the other groups which were around 0.7, 0.6 and 0.5. So definitely when you look at this picture, looking at the anterior segment OCT and trying to see which form of which of these is contributory, just about a third of these eyes you are seeing the lens as being the primary force. You have another paper, and this first paper was from China. The second paper is from Iran, and in Iran they again they found that about 25% of patients, the primary cause was suspected to be the lens vault, and it was a secondary cause in addition to pupillary block and Plato iris in another 10% of patients. There's a third paper which saw what happens to these parameters once you finish the YAG laser iridotomy. So these two studies that I showed you are untreated eyes. So once you treat, what happened? They again divided them into these 4 categories. And what they found was that once you divided it like this, just 4 out of the 118 eyes were actually, or 3% of the eyes were actually lens vault. The rest were fitting more into the other mechanisms. But there are 2 caveats here. One, that this paper that I last paper was from a Polish population, which is Caucasian. The other populations were either Asian or Iranian. And the literature from the Asian population generally tells you that the lens vault is between 70 to 35% of the population is, the lens is the primary, is significant, the lens vault is significant. So do Indians behave like Asians or Caucasians? And that's an interesting question. And there is this paper out of Singapore published some years back. And they looked at the rates of acute angle closure in Singapore as a city. And they found that the highest rates of acute angle closure was among Chinese. The second highest was among Malays and Indians. So Indians don't come close to the Chinese eyes. We are more closer to the Caucasian eyes when it comes to the way that our angle closures behave. And most of us over here don't see acute angle closure as commonly as our Chinese colleagues do. So going back to the study from the first study from Asia that I showed you, that also had a few Indian patients. Not many, about 15 patients or 10% of the patients were of Indian origin, and none of them had an exaggerated lens vault, as compared to about 1/3 of the Malay patients and as compared to more than 30% of the Chinese patients. So it's a very small number, but among those 15 Indian patients, nobody had an exaggerated lens vault. Keep in mind also that the lens vault became significant in the eyes with the shortest axial lengths. So this group had the shortest axial length in all the other 3 types. So is the lens the real culprit in all PSEG? Not really. So what are the numbers in India where it's significant? I don't know. Maybe 20%, maybe 15%, but not more than that. And we still have no information as to how it changes post-LPI in these eyes. Because if there's a pupillary block component also, you might see a improvement in the lens configuration. So I'll just briefly talk about the EAGLE study just to tell you 2 things. One was it was for PSEG and for severe PSC, that is IOP more than 30. And they wanted to see what happened with intraocular pressure. And at 5 years post-YAG-PI, they had a marginal change in intraocular pressure of 1.2 millimeters of mercury. And there are multiple factors that they looked at, but keep in mind that the differences that they saw were pretty small. In fact, in PSC alone, they did not find a difference. In PSCG, they found that lens thickness improved. This is the combined data that they published, but if you look at the graphs, that's what you will see. And most importantly, they did not publish any gonioscopic data on what happened post-LPI. And what I have shown you in the last 3 papers is that that YAG-PI makes a difference to the configuration post once you do the procedure. So if you don't know what happens post YAG-PI in our eyes, it's very difficult to say that the lens is the culprit. So is lens extraction a remedy? Clear lens extraction? Definitely not for all PSCD. may have a role for a small number of people if you have a very narrow angle after YAG PI, which is persistent, which is increasing sine K, or if there is uncontrolled intraocular pressure with medications. To my mind, these are probably the only indications where I would even consider a clear lens extraction, because these are also the eyes where you are most likely to have a problem with cataract surgery. Thank you once again.
Thank you very much, Dr. Ronnie. Now we come to our last talk of the session by Dr. Girija, Senior Consultant in Glaucoma and Cataract at Little Flower Hospital, Angamali. Dr. Girija is going to speak to us about management of angle closure and challenges faced during cataract surgery in shallow AC. Over to Dr. Girija.
Good morning, everyone. Management of angle closure glaucoma and challenges in cataract surgery in shallow anterior chamber. So these are difficulties that we commonly face. A 60-year-old female presented to a casualty. She was referred from a nearby hospital. She was being treated there by a physician for headache and vomiting and eye pain. Later only she complained about the eye pain and they referred her to us. And she presented with all the typical features of acute angle closure. That is, there was corneal edema, circumcorneal congestion, flat anterior chamber and a mid-dilated non-reacting pupil, and the IOP was in the 60s. Gonio was difficult to do in the affected eye, but the other eye showed occludable angles. So this acute angle closure glaucoma, it's a emergency, ophthalmic emergency, which is potentially blinding, and it has to be treated. Timely treatment is very important. What is the mechanism of intraocular pressure rise in angle closure glaucoma? In acute attack, there is a sudden blockage of the trabecular meshwork, and it is by the appositional closure or the synochial closure. So when it's reversible, it's appositional. But after an acute attack, sometimes the synochiae may remain permanent. It can even extend through the circumference, and it can result in a chronic angle closure glaucoma. So that is why even after doing a PI, you have to follow up the patient and see whether the disease is progressing. And medically, the treatment is based on reducing the acosumor production or increasing the outflow, and also by reducing the volume of the acosumor and the vitreous by using the acetazolamide, in the hyperosmotic agents, and the various topical anti-glaucoma medications, and along with the most important, the topical steroids. But the treatment of choice is laser peripheral iridotomy. And in an acute attack, there is no doubt you have to do once the diagnosis is established, because it will help to relieve the pupillary block, and also it will prevent future attacks. But after the PI, always do a gonio, see whether the angle has opened and see whether the IOP is controlled. And if the IOP is persistently high, then again you have to start anti-glaucoma medications and regularly follow up the patient. The various surgical treatment options are mentioned here. Surgical iridectomy usually nowadays not done because LPI has largely replaced it, but sometimes because of the unresolving corneal edema or severe iris edema and the inflammation is not getting controlled with the steroids, you may have to do the surgical iridectomy, especially in case of secondary angle closure where the following retina surgeries, you may get persistent inflammation and the PIs that you do get continuously blocked. So repeated closure and the patient presenting with acute features. Then you have to do a surgical iridectomy. Then along with other procedures like TRAB and others, you do a surgical PI. Then goniosynochial lysis is another procedure where there is synochiae which has to be released. Along with cataract surgery, if there are synochiae, you can mechanically strip the PAs away from the trabecular meshwork using viscoelastics or an irrigation cyclodialysis spatula under direct or indirect visualization. But there is limited evidence about its effectiveness. Only thing is that can be done along with cataract surgery. And trabeculectomy is done only in cases with uncontrolled IOP with maximum medical treatment, and there is in spite of the PI. And the synochiae is extending. If it's more than 190, usually you have to do a trabeculectomy. And if the patient is showing poor compliance and allergies, that's also very common nowadays, allergy to the various medications. So you may have to do a surgical treatment. And it has to be, a surgical PI is a must in an angle closure glaucoma. Otherwise, the patient can develop a malignant glaucoma later. And also the use of intraoperative antimetabolites is also advised. so that the surgery result can last longer. The newer options are like the minimally invasive glaucoma surgeries. The various options are there, and these are nowadays being tried along with phacoemulsification. Any procedure can be combined, and available evidence suggests that cataract surgery in combination with mix can be safely and effectively performed in angle closure, but long-term studies are required to see the results. GDs are indicated when the trabeculectomy fails, but only thing is that the tube can result in placement of the tube in the anterior chamber. It can cause endothelial cell loss. So in pseudophakic eyes or aphakic eyes, you can place them safely behind the iris, but the problem comes in phakic eyes. The cyclodestructive procedures are indicated in end-stage diseases with poor visual potential and symptomatic patients. It's a destructive procedure, and there is always remember that in any surgical procedure in an angle closure patient, it can lead to a aqueous misdirection syndrome, which has to be properly managed medically with cycloplegic mydriatics and steroids. When there is coexisting cataract and glaucoma, the debate is whether to do a phaco alone or a phaco trap. Always see that when angle closure glaucoma with an uncontrolled IOP, you have to choose whether to do a trap alone or to do a phaco trap. So if it's very high IOP, it's better to do a trap first, control the IOP, later followed by phacoemulsification. And when there is no cataract with uncontrolled IOP, better to do a trap alone. A lens extraction is again, never do a clear lens extraction, because as Dr. Roni has clearly demonstrated, the role of lens vault is not that important in Indians. So you don't have to do a clear lens extraction, but cataract if present, even if it's an NS 1 to 2, it's better to do, because otherwise the patient may have to undergo a second procedure. What are the challenges that we face when we do a shallow AC, cataract surgery in a shallow anterior chamber? This is actually a very, has to be done very carefully because of the limited surgical, the working space is very limited because the phaco probe is very close to the corneal endothelium and endothelial cell loss can occur. And even because these eyes are smaller, and even a standard sized incision can cause astigmatism, more astigmatism, and so there is poorer postoperative refractive predictability. And these are the various causes of the shallow anterior chamber. Usually what we see is a short hyperopic eye, but it can be other conditions like microphthalmos or nanophthalmos. Always do a thorough preoperative evaluation. That's very important. Do a proper gonioscopy and see whether the angle has opened or not. Otherwise, take the necessary precautions. And a thorough slit lamp evaluation is required, and do a specular microscopy. Biometry is very important here, and you have to take the axial length, IC depth, and IOL power. And UBM also can aid in diagnosing an ANOF if the axial length is less than 21. And preoperative subtle UV effusions, if you detect in UBM, you can treat them before cataract surgery. And the axial length, biometry, there are frequent errors in the axial length measurement in short eyes. So that you have to take care. And accurate prediction of the effective lens position is also very difficult in short eyes. And high power lenses, they can have some errors up to plus or minus 1 diopter. So you can use either the Hofeque formula or the ACRS website. And even 1 millimeter error in a normal eye can induce 3 diopter error, but in a short eye it becomes around 4 to 5 diopters. And it's better to put foldable lenses in the small capsular bag. And the intra-op challenges and solutions. So do a laser PI before surgery, because it will open up the angle and it will increase the anterior chamber depth and release the surgical maneuvering. So, and if you cannot do a PI, like in a phacomorphic glaucoma, always dilate on table. Don't do a PI, but dilate on table and you can proceed. And any posterior synechiae, they release them using viscoelastic or saline. And always stain the capsule, because it will reduce the elasticity and it will improve the visualization, and it will help you not so that the rhexis will not run away when you are doing. And always inject a high viscosity OVD to create and maintain space for rhexis, and it will also help to flatten the anterior capsule, because it will be rounded in most of these cases. So it will flatten them so that you can do a rhexis easier. And when you are doing phaco, always trench the central nucleus and clear the central part so that the phaco probe will be away from the corneal endothelium. At least that much of injury you can reduce. And when you are always during all procedures inject visco and deepen the anterior chamber, and when you're implanting the IOL, again inflate the AC and the capsular bag and inject them safely. And after IOL implantation also wash the OVD thoroughly from the anterior chamber as well as from behind the IOL. So these are the small precautions that can help you when you are doing in a shallow anterior chamber. So the take-home message is PACS is not all cases require PI, but in acute angle closure, don't forget to do PI in both the eyes. And regular yearly follow-up after PI in PACS is always advisable. Do gonio after PI and always dilate after PI and do a thorough fundus examination. And thorough pre-op evaluation, accurate biometry and specular microscopy before surgery. And control the IOP before surgery that can prevent occurrence of malignant glaucoma, and use high viscosity OVDs but wash them thoroughly before completing the surgery. Thank you.
Thank you, madam, for that excellent presentation. Now the session is open for questions.
Anterior segment surgeons, we are not. That's not an alternative procedure for PI. PI is a very simple procedure, which is usually done preoperatively. Intraoperative PI. That also can be done, but it becomes a surgical thing. Actually, we in secondary glaucomas with repeated closure, surgical PIs are being done nowadays. Along with, if you are doing a cataract surgery following the retinal surgery, you can do a preventive, prophylactically you can do a surgical PI.
Can you use the mic, sir, please?
Instead of 4-mirror or 2-mirror, I prefer to do a single mirror gonioscope examination in all the shallow anterior chambers. Then you rotate. As you rotate, you can see the zipper opening up. That gives a good clue about PAS or whether the PAS can open up or shiny cave will open up or not. That's my experience.
So for the PI which had retinal hole with operculum, was the energy too high or was the focus posterior?
I don't know, actually it was done elsewhere, and actually this one eye came, as I said, 17 days post YAG PI done elsewhere, and he came actually 15 months with exactly the same in the other eye. Again, a retinal hole corresponding to PI in the other eye. Well, probably not necessarily energy, maybe PI was done, and maybe if it is, suppose sometimes we try to enlarge the PI, maybe that shot maybe has gone through, Yeah. But I mean, here, but even posterior mode, is just going just behind the iris. This has gone and hit the retina in both eyes.
So what is theoretically described is it's a shock wave. Because when you do the PI, you set up a shock wave which goes and bounces off the retina, and that can cause the vitreous to bounce back and cause traction. Because if you have ever done a posterior hyaloidotomy for a subhyaloid hemorrhage, it's very difficult to focus that posterior. So
Correct.
unless you're putting an appropriate lens and you really go deep, it's very, very difficult to do that. So most likely it's a shock wave, because with the periphery of the lens, the peripheral portion of the lens doesn't have that amount of power to focus it back
On the retina.
Symmetric can be just by chance alone, but don't forget that's the closest place to the shock wave. because it's in the same.
And
general area.
in line with the
Yes.
laser, yeah. And as I said, one eye was 17 days post, and the other eye 15 months post. Same patient.